Hi, Dr. Scott Jensen here. It's time to talk about the heart again. There's been news breaking, and I think people are a little confused. So let's get back to some basics. First off, we're going to be talking about the heart. There's three parts. There's the plumbing, there's the electricity, and there's the muscle itself that does the contracting so that blood is forced to the rest of the body, the brain, the vital organs, the muscles, the extremities, the GI tract, and all the organs that are dependent on blood. So I'm a pilot. I fly high-wing airplanes. So what I want to talk to you about today is the news is talking about why did the FAA change some of the regulations regarding requirements for EKG standards with commercial pilots insofar as what their EKG looks like when they're having their examinations. Let's go back over this again. Basically, we have the upper chambers of the heart here. Those are the atria. The bottom chambers are the ventricles. There's a right and a left atria. There's a right and a left ventricle. That may be reversed for you because of the mirror aspect of a live Facebook video that I do myself. Bottom line is you have an SA node or a sinus node in the upper part of the heart in the right atrium. That impulse starts, that's your intrinsic pacemaker of your heart, is the sinus node in the right atrium. That goes off about every second, which would give you a heart rate of 60 seconds. If you have a heart rate of 90, then it would be going off perhaps 0.7 or 0.8 seconds. That can be calculated. So the impulse goes from the sinus node down electrical pathways to the midpoint of the heart functionally, which is the AV node. And then the AV node gets that impulse, holds onto it for just a few milliseconds, and then disperses it to the bottom part of the ventricle, which causes a contraction and the heart pumps. What we're seeing right now in the news is concern about the PR interval. So let me just show you what a PR interval looks like. Again, I understand this might be backwards, but we have an impulse that starts with the P wave and ends with the R, and that's a PR interval. Generally, on an EKG strip, I highlighted in yellow the PR intervals. And when I look at an EKG, I look to see if that PR interval is between 120 and 200 milliseconds. Now, a second is 1,000 milliseconds. So if I'm looking for something that's 200 milliseconds, that's 1/5 of a second. Very quick. But the PR interval, which basically takes the electrical impulse and it represents triggering the atria or depolarizing the atria to the time that the ventricles, the lower part, are triggered or depolarized. So the formal definition of the PR interval would be the time between atrial depolarization and ventricular depolarization. Abnormalities in this PR interval can be problematic. For instance, if the PR interval is less than 120 milliseconds, that means things are happening too quickly. That means that you could have something like a Wolff-Parkinson-White syndrome, and that can be problematic and could push you towards rhythm disturbances, which can even compromise your consciousness. You can understand why this would be an issue with pilots, commercial pilots, who are in charge of hundreds of people in their seats. If the PR interval is longer than 200 milliseconds, that means it's taking too much time. And things that we see doing that are the most common is if it's more than 200 milliseconds, we call it first degree AV block. Now, first degree AV block means that at that midpoint node that I talked about, the sinus node sends an impulse that goes down the atria, gets to the AV node where it's momentarily held up and then distributed to the ventricles so that a contraction can occur. At that AV node, if it's more than 200, if the PR interval is more than 200 milliseconds, that may well be that the AV node is malfunctioning. We call that typically, if the only thing we see is more than 200 milliseconds for the PR interval, we'll call that a first degree AV block. That can be a benign condition, or it can be a harbinger of something worse to come. Dr. Tom Levy made a recent comment saying this: the tiniest increase in the PR interval meant over time you had 2 times the chance of having atrial fibrillation, 3 times the chance of having an abnormal or slow enough heart rate to need a pacemaker, and 1.5 times the chance of dying from anything or all-cause mortality. Now, Tom Levy is an attorney and a cardiologist, and this is what he was recently quoted as saying. What I think you might find interesting is that we worry in the world of primary care medicine, does a first degree AV block have a likelihood of progressing to a second degree AV block, which is worse? There's 2 different kinds of second degree AV blocks. There's a Mobitz 1 and a Mobitz 2, but a Mobitz 2 frequently will require a pacemaker to be placed. And after a second degree AV block occurs, there is a third degree AV block. And that's where there's a separation between the electrical activity of the atria and the ventricles. And you're basically not getting the impulse of the sinus node triggering the ventricles ultimately, because they have been totally blocked at the AV node. And so you have a third degree block. These are the reasons why people are so concerned about what did the FAA do. Well, in October of 2022, the FAA made a change that would guide aviation medical examiners, or AMEs. They basically said, we're not going to just call it first degree AV block if the PR interval is over 200 milliseconds. We're going to make a distinction. If it's over 200 milliseconds, is it way over, like more than 300 milliseconds, or is it between 200 and 300 milliseconds? That was the change that was made. I follow this pretty closely because I'm a pilot, though I certainly am not a commercial pilot. Basically, the new standard became, if you have a first degree AV block or a PR interval that's over 200 milliseconds, but less than 300 milliseconds. If you're the examiner and you have no concerns and there are no symptoms coming from the patient, you can go ahead and provide clearance. However, if you have a first degree AV block that's more than 300 milliseconds, now you need to go ahead and do what has typically been done in the past. If a pilot is identified as demonstrating a new first degree AV block or a PR interval that's longer than 200 milliseconds. And that would be getting a cardiology evaluation and oftentimes a Holter monitor, where you monitor the rhythm every day for a month to see, is there any evidence that this prolonged PR interval, which constitutes a diagnosis of first degree AV block, is that causing a problem for this pilot that could be significant, potentially leading to an alteration in consciousness, alertness, or the ability to operate a plane. That's what happened in October of 22. The clinical significance of a first degree AV block is typically said to be this: although first degree block is not usually serious by itself, it can be a precursor to a more serious type of block. Usually, treatment is not needed unless other serious signs or symptoms are evident. There was a physician, I had a busy day with a lot of EKGs being done. I think I had a half dozen EKGs being done. I always look to see what is the PR interval, and if it's not between 120 and 200 milliseconds, I want to know what it is, and I want to know what it was. So I'll go back to an old EKG and say, have we seen a change? Did we see a normal PR interval now become prolonged? Because if we did, that is a red flag, and we've got to pay attention to it. Dr. Peter Chambers is a retired U.S. military special operations flight surgeon, and he made a comment that he agreed it was unwise for the FAA to change the PR interval limit. Now, the FAA's representative has said that this has nothing to do with the COVID vaccination. But yet that's clearly on people's minds because we've recently seen a variety of concerns regarding arrhythmias. I had done a video 10 days ago regarding the changes in EKG parameters in senior high students that occurred after an mRNA vaccine. So we're concerned about young people dying. We're concerned about changes in young people's EKG after receiving a vaccination. In the BMJ journal on heart, there was a study by Norbert Gutler, and this study was in the volume 105, issue supplement 1. And in the abstract, it said this: the decision regarding restriction of flying activity will be dependent on several factors, including the underlying arrhythmia, first-degree AV block in this situation, associated pathology. That means we have to look a little harder to find, is there a problem with the heart that we weren't aware of? Risk of incapacitation and or distraction. In other words, if you're flying an airplane with hundreds and hundreds of people as passengers, and you're flying tons and tons of metal, and you get distracted because you're having palpitations, discomfort, or a sense of breathlessness, that's a problem. The type of aircraft operated. What kinds of capacities does it have? And does it have a left and a right pilot? Left seat, right seat pilot. And the specific flight or mission criticality of the role performed by the individual aircrew. These are the reasons why we pay attention to the EKG. This is why at 35 years of age, a pilot will have an EKG if they're a commercial pilot. So this is what the hubbub is about, is we have this PR interval, and the FAA a few months ago changed the standard and said, if it's above 200 milliseconds, that doesn't necessarily mean you have to do something different. And they went ahead and said that if it's between 200 and 300 milliseconds, in other words, it could increase up to 50% longer. If that's the case, but there are no symptoms, you can go ahead and issue clearance. But if it's more than 300 milliseconds, you do need to get that cardiac evaluation and a Holter monitor or something like that. I think that's the concern that people are having right now, is are we seeing a quiet change in a regulation made in light of the fact that we may not have enough pilots? A lot of pilots have been vaccinated. A lot of EKG changes have been identified following vaccination. Do all of these things add up to a concern? Is a pilot in charge of the aircraft you're flying in as securely safe as they might have been prior to October of 2022? Pilots are calling me. Physicians are calling me. I've had FAA physical exams. I read EKGs all the time. Am I surprised that the standards for the PR interval have been changed in light of all that's been going on? I am. To me, this would be a time where we would hold to the high standards that we've had in place. And if someone reflects a PR interval outside the range of 120 to 200 milliseconds, it seems to me that I should be as obligated as ever, or more so, to evaluate. And that evaluation has to include the question, does this represent a change? And if it does, why in the world would I not thoroughly evaluate what that change is, What other impacts might it have on the function of the heart? And could it be related to something that's happened recently to the pilot's health? That's why people are concerned about the FAA changes regarding the PR interval and the possible minimalization of a diagnosis of first-degree AV block. I hope that helps provide some understanding of what the conversation's about, particularly over the last few days. Have a good night.